Greetings of the day, folks. Today we are going to discuss about another member of herpes family, that is cytomegalovirus. It is also a double-stranded DNA virus. Now let's dive into the various nuances of the disease. So cytomegalovirus causes a wide variety of diseases ranging from either asymptomatic to most life-threatening pneumonia, mainly seen in transplant patients. Okay, so like other herpes virus, it causes primary infection, then recedes into lifelong latency. It sleeps into some state in latent phase. Okay, and cytomegalovirus, unlike other viruses, it is not highly contagious, and transmission requires repeated or prolonged exposure. The virus is spread by sexual contact, saliva, breastfeeding, and transplantation, as well as transplacentally and through blood transfusions. Seroprevalence rates approach 100% in Africa and in some Asian countries. In the developed world, it is not unusual for older individuals to acquire a primary infection. This is of particular concern in women of childbearing age because teratogenic effects. The risk of fetal cytomegalovirus infection is highest in the first trimester of pregnancy in a previously seronegative mother who acquires a primary infection. Organ transplant patients can acquire infection most often between 1 and 4 months of after transplant. The risk is highest when a seronegative patient receives a cytomegalovirus positive organ. Pathophysiology. Cytomegalovirus is usually inoculated on the mucosal surface of upper respiratory or genital tract where the virus multiplies and then disseminates into the various organs. So most infections are only mildly symptomatic. Primary disease in late adolescence and adulthood results in infectious mononucleosis syndrome. The virus remains latent in most individuals unless immunity is suppressed. What are the clinical features? The clinical features are the primary infection in healthier individuals are usually asymptomatic. Cytomegalovirus can cause heterophile negative infectious mononucleosis syndrome characterized by prolonged fever, myalgia, and atypical lymphocytosis. But the most important thing to remember is there is no exudative pharyngitis and there is only mild lymphadenopathy. Okay, so severe disease in otherwise healthy individuals include and otherwise healthy host includes hepatitis, colitis, Guillain-Barré syndrome, encephalitis, and hemolytic anemia, as we have discussed liver, intestine, neurological, and also the hematological. Okay, so congenital and neonatal infections have some of the most important complications of primary cytomegalovirus infection. Symptoms in infants can be devastating and include hepatosplenomegaly, jaundice, microcephaly, petechiae, and growth retardation. Severe infections carry a high mortality, and those who survive often have neurological sequelae. Infections in immunocompromised patients can be severe and involve any organ. Infections can be primary or a result of reactivation of latent virus infections. Okay, so severe disease can develop in previously healthy cytomegalovirus seropositive individuals with abnormal T cell response during critical illness. So infections after solid organ and hematopoietic stem cell transplantation are a leading cause of morbidity. In HIV in patients with CD4 count of less than 50 cells per millimeter cube, retinitis is most common manifestation of the infection, causing painless loss of vision. Okay, so the other manifestations include encephalopathy, colitis, peripheral palsy, radiculopathy. So how do you diagnose? Normally, diagnosis is not usually made in ED. Body fluids such as urine, saliva, blood, tears, semen, and vaginal fluids are antigen. Polymerase chain reaction and antibody tested, and tissues examined for culture and or cultured for diagnosis. The hallmark of cytomegalovirus infection on histological examination is a large cell containing a large basophilic intranuclear owl's eye and intracytoplasmic inclusion body. So there is what intranuclear owl's eye and also intracytoplasmic inclusion bodies. Okay, so these are the main pathognomonic features. So coming to treatment asthma, there are no medication because it is self-limiting and it will be resolving on its own, but there are several systemic antiviral agents that are active against cytomegalovirus that include ganciclovir, valganciclovir, foscarnet, and sirofovir. And these medications should be given only after consultation with ID specialist or transplant specialist. So illness in the otherwise healthy host is usually self-limited and does not require any antiviral treatment. Cytomegalovirus-induced infectious mononucleosis is treated symptomatically. So if the patient has fever, you give an antipyretics, and if you pain, then give pain medication.